Good morning, good afternoon, good evening. Welcome to this session on international development and social welfare. We're going to give people 2 to 3 minutes to join, and we're really looking forward to this session. My name is Vivian Welch. I'm Editor-in-Chief and Interim CEO of the Campbell Collaboration, and I'll be chairing this session and hosting it. And while we're waiting for people to join us, I'd just like to also thank our sponsors, the Pan American Health Organization, the Evidence-Based Medicine Center at Lanzhou University in China, and Canada's Drug and Health Technology Agency, CADA, as well as our panel sponsors and partners, UNFPA, the Peers Program, Epicenter, and the Ministry of Foreign Affairs. So we'll give just one more minute for people to join. Okay, welcome to all of our participants. I'd like to welcome you to this session on international development and social welfare. We have 3 speakers with us now and one trying to work out the technology. Miriam Nkangu from University of Ottawa, Liang Zhao from Lanzhou University in China, and Thomas De Hoop from American Institutes for Research. I'd like to invite Miriam to start us off, and I will just share your slides.
Okay.
One moment while I get that working. Dr. Nkangu is a PhD candidate at the School of Epidemiology and Public Health, and she'll be presenting about a systematic review on the effects of performance-based financing interventions. I'll turn the floor over to you, Miriam.
Thank you. Okay, so maybe we just go to the next slide. But before I start, I would just want to acknowledge my co-authors on this systematic review. And so we can move to the next slide. Thank you, Vivian, for the introduction. And I will just dive into the core of the systematic review. So actually, performance-based financing is a supply-side strategy which aims to incentivize healthcare workers. And the goal is to improve quality and quantity of care, but there are predefined criteria. And this policy was introduced by the World Bank or advocated by the World Bank, mostly in low middle income countries for the past 10 to 20 years. And my systematic reviews is actually focused on sub-Saharan Africa. Over 26 countries in sub-Saharan Africa is implementing this program, and some countries have actually adopted it as a national policy. So one of the assumptions of the program, performance-based financing, introduced equity component, which is called the performance-based financing equity instruments. And these instruments lay down some assumptions and elements that they need to be followed to be able to improve access and utilization of services, specifically by the poor and vulnerable. And this equity element one of it assumes that subsidizing user fees will help improve out-of-pocket expenses by reducing it, and then stimulate demand for service use by the poor. So this implies PBF can be seen as a behavior change mechanism. So in that way, healthcare providers are being incentivized and then to be able to stimulate, create demand in order for poor and vulnerable women to use maternal and child services, especially in very rural areas. So we actually use the framework by Anderson to actually assess this review using the behavioral model for Anderson, because it has been widely used to assess the utilization of health services. And we focus mainly on contextual and individual characteristics, because performance-based financing policy is highly contextual, and it's important to look at it from that perspective. So our key questions for this systematic review was, first, we wanted to look at, because previous review have actually looked at performance-based financing in low middle income country, though this one is actually focused on sub-Saharan Africa, but most of the reviews actually assess out-of-pocket expenses as a secondary outcome, but in an aggregated form. And out-of-pocket expenses does not only include consultation fees, as mostly used by most of the reviews. Out-of-pocket also include consultation, providers fees, you have laboratory fees, you have medications. So all those are part of out-of-pocket expenses as defined by USAID. And so the difference between this review and the other reviews is basically disaggregating this for us to look at it from how is PBF actually impacting each of these out-of-pocket items, and how is it stimulating demand and improving access and utilization of maternal services, specifically antenatal care, skill birth delivery, and family planning. That was the focus of this review, mainly because antenatal care, skill birth delivery are important indicators in monitoring maternal mortality, and maternal mortality is still a burden in sub-Saharan Africa. So our question for this review was, what are the PBF supply and or demand side strategies that have been implemented to improve or reduce out-of-pocket expenses? So we wanted to identify, because we tried to identify what were the existing policies in place before PBF, existing policy in terms of reducing out-of-pocket expenses for maternal and child health services, and after PBF, what were the strategies that have been implemented to improve on that. And then whatever strategies that were implemented as a result of PBF, we wanted to also look at what's the effect on out-of-pocket expenses. Is it changing access and utilization? Next slide. So with this, we actually search over 5 to 6 databases, and we actually came out with the total number of papers included in it was 9,000, that we screened was 9,025 papers. And I know this is really not visible much at that end. Let me try to expand. Sorry about that. So 286 papers met full text criteria for screening, and then a total of 16 papers was included in the review, of which 10 met the criteria for grade assessment. So one of the reasons why we actually focus on contextual and individual characteristics is because it is important to understand that in the context, in most sub-Saharan African countries, healthcare is delivered by both public, private, and faith-based health facilities. And performance, these facilities may also vary in the way they actually deliver care, and also their organizational culture, the quality of care provided. All these factors have a role in playing with demand and supply side for utilization of maternal and child health services, and cost, because the cost in public facility may not necessarily be the same in the cost in private facilities. And with the introduction of performance-based financing, were there any changes? How is it playing with these costs with both sectors? And then in terms of the individual aspect, how are women responding to services? Are they actually using services after the implementation of PBF? So our next slide. So for the sake of time, I will not go detail into some of the components. I will try to be more explicit in some. So in this, we conducted a risk of bias after screening and identifying the full text onto the included papers, the 16 papers that we included. We categorize our table with the existing policies, which I earlier mentioned, that were in place before PBF, and then policies that came after PBF, with a focus of improving equity. And most of the studies, as you can see, actually, they were mostly low and medium, low quality studies, with very high, with the risk of bias tool that we used. They had very high allocation and concealment. Most of them were not randomized control trial. Most of them were mostly control before and after study. So we had control before and after studies. We had interrupted time series analysis. I just presented a few of them here. And the ones that I presented here are mostly the control before and after study design. We had a few papers also as randomized control. Just about 3 papers were randomized control, but the rest were mostly control before and after study design. So, but most of the papers were of low quality. So we actually conducted grade, and the rationale for conducting grade, we couldn't conduct a meta-analysis, and because of the way that the results were presented, there was a lot of heterogeneity in the way they presented the results. And so we couldn't conduct meta-analysis. However, we presented results using the grade summary table without conducting a meta-analysis. And so we actually converted the effect size estimates that were reported to a harmonized scale that can be easily interpreted using the relative change. And this was actually, we actually used what was used in one of the Cochrane review that was published just recently on similar study, with the difference in what we have just mentioned from the onset, as we focus more on disaggregating out-of-pocket expenses. So we found out that in Tanzania specifically, the introduction of performance-based financing, just as it has been mentioned in some of the papers, how PBF equity program, or PBF in general, may be seen as a pro-poor policy in Tanzania. We actually found out that PBF actually facilitated the removal of operational barriers within the health facilities, because it's before the introduction of PBF, there were some existing policies in place to improve or to reduce out-of-pocket expenses. But some of these policies were not very much effective, because there were still some maybe hidden costs or some operational barriers that still impede access to using skill-based delivery and ANC. But this actually it had more effect on the use of skill-based delivery. So skill-based delivery, we actually could see an improvement in the women who actually paid for out-of-pocket expenses for skilled birth delivery, the probability of paying actually reduced compared to the control group. But in other countries like Burkina Faso, there was no much change. So even there were a few policies in place, and with the introduction of the equity policy, in addition to a national policy that actually removed out-of-pocket expenses, but there was no impact on the poor. However, the study also did not actually assess the policy over a specific period of time. So there were some limitations in that. And also, some of the studies also did not actually provide detail about how it is being implemented in, like the effect. They did not disaggregate most of the data in terms of private and public facilities. Some did, but some did not, which was one of the observations we also found out. And in Tanzania specifically, this was actually disaggregated, and it actually showed that this improvement or this effect was greater in public facilities, though they had a general improvement in of paying for out-of-pocket expenses. Most women didn't pay, but this was more effective in the public health facilities. Next slide, please. So in conclusion, what is important to note about the key things that we came out from this systematic review is, first, our systematic review found out that performance-based financing facilitated the removal of operational barriers, which I initially mentioned, to enhance the utilization of certain maternal health services, especially skilled birth delivery. And it is important to also note that most of the studies on out-of-pocket expenses or user fees in sub-Saharan Africa that has been investigated to see the difference with the role of user fee in accessing and maternal health services, has also found out that with the removal of user fee, it actually has more impact on the use of skilled birth delivery. And another thing we observe in the review, which is an important finding, is the use of the scale in assessing who is poor and vulnerable. So in most of the reviews, there was no definition of who is poor and vulnerable. However, the scales that were used in most of the review actually assess poor based using household characteristics and asset index, and then scale it using the quantile, 5 quantile differences. But none of the papers actually defined the poor, vulnerable in that context, and to align it with the way PBF may be identifying or defining who is poor and vulnerable. Now, the important thing to observe here is one of the studies actually highlighted this as a limitation, one of the randomized control study, because they use the household characteristics asset and index scale, but they highlighted the difference.
One more minute, Miriam.
Thank you. But they highlighted this as a limitation. So one other thing we found was the reported delay in payment, which also affect the way they may want to improve or change their behavior in terms of out-of-pocket expenses, reducing it to stimulate demand. So if there is a delay in paying their equity incentives, there is also the impact on the way they want to deliver care to those who are poor and vulnerable. So thank you so much for this, and that's the last. Those are the references that I use.
Great, thank you, Miriam. That was great. I think I'd like to encourage participants to enter questions in the live Q&A. These can be addressed by our panel, and we'll move on to the next speaker. And if we have time at the end, we can have a panel discussion. So I'd like to invite Liang Zhao to share your screen and give your presentation. And just while you're pulling that up, Liang Zhao will be speaking about child marriage and evidence synthesis. And she's based at Lanzhou University. I have just lost your screen, Liang Zhao. Okay, now we see you. Great. And can you share your slides? Let me unmute you. Okay, can you share your slides?
I have shared my slide.
Oh yes, I see them. They are on the last slide. Would you like to put them to your first slide?
I begin my presentation.
Yes.
Okay, thank you. Thanks for.
Could you please put the slides on your first slide, because right now they are on the last slide that says thanks.
Oh, maybe the internet, because the internet in my hair. This is my first slide.
Okay,
now,
perfect. Yes, go ahead.
Okay. Hello, everyone. Thanks for this introduction. The topic. My name is Liang Zhao. I come from Lanzhou University, and the topic I shared is child marriage. What we are working on. We aim to conduct a thematic analysis of child marriage research and identify research trends which provide reference for future research. About its method, first we search the website database and the search terms as follow: child marriage, child bridge, and so on. The search term on May 2022, we include the article and review about child marriage, and the network map of keywords and institution was generated by Weaver, and the deal map overlap of journalists and keyword burst were generated by Sitespace, and the collaboration word map were generated by Biometrics. Finally, we include 696 publications that were published from 1978 to 2022.
And now, could you could you move your cursor to the yes, so we can see the slide? Thank you.
You can't find my slide?
That's perfect there. Now we see your map of the studies with the red, blue, and green. This is perfect. Please continue.
Can I continue?
We see your screen.
Now can you see my slide?
Yes.
Okay. Finally, we include 696 publications that they were published from 1968 to 2022, and this study was conducted in 85 countries, and among these countries, the America ranked first. Then this we include a study were published in 364 journals, and there were 25 citation pages in the dual map overlap, And this path suggests that much of research on child marriage have focused on psychology, education, and health. And 777 institutions participated in child marriage research. Among this research, United States of California, Santiago ranking first. And from this network map of institutions, we can find that there were 1, 2, 3, 4 collaboration groups that work close together both within and between the group. The keyword cluster analysis stated that child marriage research focuses on the following themes. The first themes, the class were this rate. The first class have made keyword child marriage and reproductive healthy, social normal, and from this keywords we can get that the class will present the impact of child marriage on child reproduction healthy, and the second cluster, the great one, and the class 2 have made keywords child, gender, forced marriage, and so on. And the class 2 explore the child right, other child marriage. Further speaking, we can get that which child rights are harmed after child marriage. The cluster 3, the blue one, the main keywords have education, human rights, and poverty. From these keywords, we can get that the class 3 speak about child marriage in related to education, human rights, wellness, refuge, healthy, and poverty. It's not only to explore health, children marriage, how to influence education, wellness. But also to explore the education, the refuge, the healthy, how to influence children marriage. And the class 4, this yellow one will make keywords woman and Africa and so on. This cluster investigate woman health inequality due to child marriage in Africa and Asia. And the class 5, this purple, and the class 5 aimed to find various wellness in child marriage because they have all kinds of wellness. And keywords burst indicated that in recent years, we can find that people pay more attention in mental health, child rights, and the noise that can protect children. And we also can get that the factor influential traits of child marriage may be a hot topic for the future. Okay, above all, our study provides a deep insight to children marriage research. In future, we should spend more energy on reducing the incidence of child marriage to protect the children, especially in low and middle income countries. Thank you.
Wonderful. Thank you. I'd like to encourage participants to ask questions in the live Q&A. That's really the best way to address questions to our presenters. I think this was a great example of how bibliometric analysis can showcase where the countries of publications, the disciplines, and the topics. So thank you, Liang Zhao. I'd like to invite Thomas de Hoop to share your slides. And Thomas de Hoop is from the American Institutes for Research. while you're just getting your slides up, Thomas will be speaking about convergence of social protection programs in India. And I see your slides now, so I'll put you on screen. Over to you, Thomas. Thank you.
Thank you so much, Vivian. You can all see my screen, right?
Yes.
Perfect.
And the audience, just to say, the audience reactions are on. So if the audience would like to clap or give a thumbs up, you can do that. As presenters, we can't, but you can. Okay.
Thank you, Vivian. And thank you all so much also for the previous presenters for the very interesting other presentations as well. It's great to be here. My name is Thomas de Hoop. I'm a managing economist at the American Institutes for Research. This is joint work with Garima Siwach, with Jemaya Holla, and with Birukusan Mahapatra from the Population Council. We're discussing the impact of self-help groups on access to and participation in the Mahatma Gandhi National Rural Employment Guarantee Scheme, and specifically in the state of Bihar, which is one of the largest as well as one of the poorest states in India. I wanted to start with some background. Increasingly, it is recognized that social protection programs by themselves also need to strengthen each other. Lots of randomized control trials and quasi-experimental studies focus on the impact of individual social protection programs, such as cash transfers, such as public work programs, such as self-help group programs as well, if we can characterize those as social protection programs. But ultimately, it's also important to look at the linkages and the convergence between these different government programs, such that governments can really stimulate the use of social protection systems. And this is something that the Indian government is focusing on a lot currently as part of a convergence strategy. And this guided some of this research, which we did as part of the Evidence Consortium on Women's Groups, which is an initiative where we conduct a lot of research on self-help groups in India, on savings groups in sub-Saharan Africa, particularly in Nigeria and Uganda. It's an initiative that is funded by the Bill and Melinda Gates Foundation, a collaboration between American Institutes for Research, the Population Council, various universities such as Stanford University, the Washington University, and Makerere University in Uganda as well as the Campbell collaboration. And as part of this research, we're examining these linkages, among others, between self-help groups, which are essentially like small microfinance initiatives, or actually rather large microfinance initiatives in India, where about 80 million women are actually participating in this program currently under the National Rural Livelihoods Mission. And they come together in small groups of 10 to 15 women to save and to receive credit as well, and as well as they engage in various other initiatives. And one of those other initiatives is they also receive information about another really large program, the Mahatma Gandhi National Rural Employment Guarantee Scheme, or MGNREGA, or MGNREX, as it's called. And they receive information about this program, which provides employment through a public work program for a minimum wage. And in theory, everybody is eligible for this program. In practice, it's not always possible for everybody to receive a job card, which enables people to work. It's the largest public works program in the world. Obviously, we're speaking about India here, so everything is really of large scale. And there are various reasons why self-help groups could actually influence participation in NREGA. First of all, the most obvious one is probably that there is greater awareness, but also that there is collective bargaining through self-help groups. Self-help groups come together, and women can actually collectively bargain to receive job cards that I was previously speaking about. Also because they come together at larger at higher levels of aggregation, for example, through village organizations where one member of a self-help group participates with other self-help group members in village organizations, which are also then aggregated into cluster level federations. In addition, there's a formal convergence strategy from the Indian government, which started post 2015. And Finally, there could be a change in labor force participation because women actually receive access to credit, and there may be various mechanisms through which this may actually influence labor force participation. So the research questions we ask are, what is the impact of self-help group participation on access to NGN recs? What is the impact of SHG participation on employment? And also, like, we examine how members of different castes in the Indian context, specifically in Bihar, how does caste moderate the effects of SHG participation? So we look at subgroup analysis here as well. So we use various data sources for this. Essentially, we're combining a previous randomized control trial of the Jivika program, which is an initiative in Bihar, which is part of the National Rural Livelihoods Mission in India. And there was a randomized control trial across 136 gram panchayats, which are collections of villages. And like for each of those gram panchayats, we have both data on self-help group participation that we scraped from the internet, and job cards, as well as participation in the Mahatma Gandhi National Rural Employment Guarantee Scheme. So we merged data from the randomized control trial, which started in 2013 or 2012, sorry, and we combined those data with the publicly available data from the GVCAP program through the National Livelihoods Mission and the Mahatma Gandhi National Rural Employment Guarantee Scheme. And this enabled us to essentially examine the impact of SHG participation on NGN-REGA because of the initial randomization. So the control group did receive the program over time. So randomization, so slowly what actually happened is that initially in the treatment group, the Gram Panchayats there had like much higher self-help group participation. That higher self-help group participation continued over the course of the study. And we have data from 2013 to 2020. But over time, also the control group catched up. So what we do is we use an instrumental variable, which basically means that we predict self-help group participation with the initial randomization. And this creates random variation in the number of self-help group members at the Gram Panchayat level, which ultimately then enables us to assess the impact through this instrumental variable analysis on participation in NGN-REGA. We're going quickly to the evidence. And essentially what we find, based on those data from 2013 to 2020, we find that an increase of 100 self-help group members increases the number of job cards applied to by 26. We cannot distinguish necessarily between the different mechanisms that we previously applied, but what we do see is also that this is likely because self-help groups often include members of the same castes. And what we see is also that the number of job cards applied for also increases more if a member of your own caste actually participates in a self-help group program. So if scheduled caste and scheduled tribe, like self-help group members, if those numbers increase, that essentially leads to an increase in the number of job cards applied for of 85, 100 scheduled caste or scheduled tribe self-help group members apply. 85 scheduled caste or scheduled tribe self-help members receive job or apply for jobs. And we see this gradually phases out. What we see is that ultimately, like if the number of SHG members increases with 100, that results in 14 NGN-REGA jobs. And that if the number of self-help group and scheduled caste and scheduled tribe self-help group members increases with 100, that results in 45 additional NREGA jobs for scheduled caste and scheduled tribe members. OBC refers to other backward castes. Scheduled caste and scheduled tribe members are generally considered the most marginalized populations. Other backward castes, as the name implies, are usually also considered relatively like marginalized populations. There's a lot of contextual variation there as well, so it's not so simple to say that necessarily this is homogeneous across villages. But what we do see is that number of self-help group members, if it increases, it seems to have higher effects on average for marginalized populations. So what we see essentially is that self-help groups can serve as a vehicle to improve access to social protection, especially for vulnerable populations. We see that by combining a randomized control trial with various administrative data that are publicly available. So this also shows the ability of randomized control trials to not only rely on like relatively expensive survey data collection, but to also make use of administrative data that are pre-existing. And what we see is that increase in self-help group outreach, in this case through the GVCAP program, improved access to job cards. And we find also that that results ultimately in improvements in the number of jobs. A focus on the most vulnerable may indeed have resulted in larger effects for both scheduled caste and scheduled tribe households. And like what we haven't spoken about yet is like the effects of the public works program, the Mahatma Gandhi National Rural Employment Guarantee Scheme itself. What we know is that that program, based on previous randomized control trials, shows positive effects on household consumption, on income, as well as private sector wages through general equilibrium effects. So ultimately, what can happen is that an increase in the number of self-help group members through an increase in the number of job cards and the number of jobs in the Mahatma Gandhi National Rural Employment Guarantee Scheme can actually also result in household consumption, income, and private sector wages through indirect channels. Like self-help groups can themselves have those effects as well, but it can also happen through participation in the Mahatma Gandhi National Rural Employment Guarantee Scheme.
Great. I'm just
What we
gonna
also
one more minute.
Yeah, it's the last bullet point, so that should be fine, Vivian. So what we also see is that like really strengthening and combining management information system data across program can provide the government India with important information about the effects of the convergence of government supported programs, which is like very important considering like the convergence strategy that the government of India has started, as well as in various other settings where it becomes really important to look at the effects of these social protection systems, not just social protection programs. That was it. Thank you so much. These are just some contact information if you would like to learn more about the Evidence Consortium on Women's Groups from either myself or my co-principal investigator, Sapna Desai, or the project director, Gary Hasila. Thank you so much.
Fantastic. Thank you, Thomas. That was great. Just in the interest of time, I'd like to move to our last presenter, Ling Wang, and just thank Thomas. I think, you know, it's a really great example of looking at the moderating effect of caste and socioeconomic status on these programs. Really lots of implications for Campbell's systematic reviews addressing these types of questions. Really encourage the participants to use the live Q&A to put questions in the for our speakers. And Ling Wang, are you able to share your slides? Because if not, I have them on screen. Yes, that worked. So yes, we see them and we see you on screen. So I'd like to pass over to Ling Wang, who will be speaking about a systematic review of randomized trials for pedestrian road traffic. And
okay,
you've timed this for 6 minutes, right? Yes, go ahead, please.
Okay. Thank you. My name is Wang Ling from the School of Public Health, Lanzhou University, and I'm presenting on systematic review of randomized controlled trial related to pedestrian road safety education. First, we need to review a few important facts. Worldwide, approximately 1.3 million lives are terminated each year due to road traffic accidents, and between 20 and 50 million people suffer no fatal injuries, which result in many disabilities. Road traffic injuries are not only a major global health problem, but also an important development issue. With a huge economic cost of 3% of most countries' GDP and 93% of the world's road deaths occur in low and middle income countries. At the same time, about half of the world's road traffic fatalities are among vulnerable road users, such as pedestrians, cyclists, and motorcyclists. Actually, many countries and regions have implemented a variety of measures to mitigate this problem, but the high incidence of the road injury also suggests that more strategies and measures need to be developed and used. And with the launch of the second Global Decade of Action for Road Safety in 2021, there is an urgent need for effective evidence-based road safety education interventions. We therefore review relevant randomized controlled trial to identify effective interventions to prevent road traffic injuries. We first conducted an extensive search to find and identify included literature, and eventually 35 randomized controlled trials from 27 publications were identified, followed by data extraction, quality evaluation, and further analysis. We can see that in terms of the countries, the vast majority of these studies were from developed countries, with the highest number coming from the United States, 37%, followed by the United Kingdom, 26%, and only 2 studies from the developing country, Iran. The studies were mainly focused on children, with only 2 trials focused on adults and older adults with intellectual disabilities, respectively. The interventions involved were even more diverse, including traditional classroom knowledge transfer, and games and videos, and the application of the innovation forms of technology, such as virtual reality and 22 trials from 16 publications report complete data on road safety education related interventions versus no contact control groups before and after the intervention. We have now extensively combined the data based on the type of the data. And the results show that the test scores of the intervention group were 0.72 points higher, and the test correct rate was 4.23 times higher than the control group, indicating a significant intervention effect of the road safety education interventions. And 11 studies with follow-up showed that intervention had a sustained intervention effect, but a lower effect than when the interventions first ended. And then we are next trying to compare the effect of the different interventions, though further analysis of subgroups to explore which interventions are more effective. And that's all I have to report. Thank you for your attention. And I put my email here. You're welcome to communicate with me if you have questions.
Fantastic. Thank you, Wang Ling. That was fantastic. That is a very big meta-analysis. Wonderful work. Ling Wang, am I correct that you have another presentation in this session?
Yes.
Yes. Okay. So we have 10 minutes left, and I suggest that, so I see some people clapping have found the audience reaction. So thank you to the audience. Can you take down your slides, Wang Ling? I suggest that we move right into your next presentation, and then if we have time at the end, we can have questions for the panel.
Okay.
So if you click on stop sharing, then you can share your other slides.
Okay, I'm trying to.
Great, that worked perfectly. Just, yes, we see your slides and they are just not in the presentation view yet. Okay, so.
Okay.
Perfect.
Thank
so,
you.
Wonderful. So again, we have 10 minutes left. So if you can keep this to about 6 minutes, that will be great.
Okay. Next, I will start my next presentation on case study of the evidence ecosystem in the social sciences. Take pedestrian road safety education as an example. In 2017, the first global evidence summit was held, and the concept of evidence ecosystem was shared and discussed in several topics, pointing to the future direction of the evidence-based research. Actually, the concept of evidence-based originated in medicine, but its evidence-based methodology and practical exploration are rapidly developing in the nature and the social science, creating a new wave of social science research. Therefore, we try to focus on road traffic safety, a long-standing and high-impact health and development issue, and selected pedestrian road safety education as an example to explore the evidence ecosystem in this field. We first conducted an extensive search of the databases and relevant websites using search terms, ultimately identifying 67 relevant studies, 22% of which were from developed countries, with 82% of which were from developed countries and 27 from the United States. And then the researchers classified them according to the type of the study and the research method. It is clear that the largest amount of literature is found in the production segment of evidence in the field of road safety education. With common research methods such as interview, observation, intervention, and literature studies. In terms of the sciences evidence, we observed 3 systematic reviews, all aiming to focus on the effectiveness of pedestrian road safety education interventions. In terms of the evaluation of evidence, only 1 systematic review assessed the quality of evidence for individual studies using Cochrane's risk of bias assessment tool and assessed the quality of the body of evidence using the grid. And then in terms of the application of evidence, we observed the guidelines, government report, policy statement, and program reviews. And we judged the process of their application of evidence by reference citation. But it was clear that a scientific methodological process of retrieving, scoring, and evaluating to the application of the evidence was lacking in all of these documents. And thus, compared to the evidence ecosystem proposed by MAGIC, the evidence cycle process consists of 6 parts, and under the field of the road safety education, we see evidence production based on the primary sources and evidence sciences represented by systematic reviews for the dissemination and application of the evidence, as well as the evaluation and improvement of practice process. Current attention is relatively limited, and more research and exploration is still needed in this field and areas And that's all my report. Thank you.
Wonderful. That was really quick. Thank you. So we have about 5 minutes for questions, and I'll maybe put us back to a gallery. I have not seen questions in the live Q&A. There's one question from Yu Huan. Will your working group try to develop an evidence ecosystem used in road safety? I think you have actually developed an evidence ecosystem in road safety. That was a beautiful summary of a lot of different studies. But the question is whether you'll develop an evidence ecosystem used in road safety. I think maybe we could ask the commenter to clarify the question in the live Q&A. Maybe while doing that, I wanted to ask a question maybe of the whole panel, but especially Miriam and Thomas, about the challenges in defining equity and vulnerable groups in your respective studies, and any insights you can offer for our participants and presenters.
Okay. Thank you, Vivian. Maybe I just go first and say what I experienced during the systematic review. Yeah, so that's a very interesting question. And like I earlier mentioned in the systematic review, none of the papers actually define what poor and vulnerable means in their context. So which means we cannot really tell how they perceive or define equity, but they use the standardized scale, the quantiles, 20, 40, 60% quantile. But what we found also is that using that scale may not necessarily define who is poor if we want to align it with the way PBF may be defining who is poor and vulnerable. And vulnerability may not necessarily means that you are poor. It may just define your state, and also the circumstantial situations that they may be using at that point in time. So there is a potential for misclassification. And that leads me to a different paper that I had to work on and to actually expand on that concept, which is not for this topic, but just to give that overview of that equity approach. And then one important thing is the data collection approach, because most of the studies also used the demographic and health survey data. And PBF was implemented in most of these countries from 2010 onwards, 2006 onwards. So most data or most studies are not collecting new data to actually use it to assess post-PBF implementation, but relying on demographic and health survey data, which may not also collect some of the variables that may really be specific in defining poor and vulnerable to align within the context of the PBF definition of poor and vulnerable. So there is still that gap in defining poor and vulnerable to address equity issues.
Excellent. Yeah, I think it's great for to highlight that in your review. Thomas, did you want to add to that? And you used CAST in your study.
I mean, I think in this study in particular, like these were the data that were available, right? Like we didn't have like major, we used administrative data, and we didn't have like detailed poverty profiles from the populations that we were working with. In general, maybe also like unrelated to that, but like possibly relevant, is like when we're thinking about different social protection programs, like there's probably also like there's no such thing as a binary variable that says like whether someone is vulnerable or like poor or not, like, and there are different levels of poverty, and like self-help groups usually do not target populations that like are living far below the poverty line. They're usually targeting people, women who can still save a little bit. Like the most poor are not usually those who are necessarily interested in participating in self-help groups. And for those, like different social protection programs are probably required in addition to self-help groups. So this is where like the social protection system also comes in, where like one program will not cover all vulnerable populations. Just some like thoughts on that.
Yeah, no, that's great. I see that they extended our time for a moment, and I just wanted Wang Ling and Liang Zhao to comment on, could I ask your thoughts on incorporating this concept of equity and vulnerability in the types of maps that you're doing? Do you assess equity in your evidence architecture? Do you assess whether studies have looked at questions of socioeconomic status and poverty within your populations? So I think there's an opportunity with maps to highlight these kinds of questions about distribution of our evidence base across for vulnerable populations. I'm not sure if that was clear. I think I will follow up with you after. I think your presentations both gave us a lot to think about. And just want to thank all of our speakers and really invite people to connect with our speakers after the session and also visit our exhibition hall and our posters. There are a number of excellent posters, especially from your colleagues, and really look forward to seeing you in other sessions. And thank you for participating.
Thank you.
Thank you.